Tallahassee, and this is the third year now that we've had the great pleasure of partnering with the Fairbanks Center to bring visiting scholars who are able to speak about ethics and palliative care to campus. A few instructions that I'm supposed to give, and then I'll introduce our speaker. If you could please silence all cell phones and pagers. If you do need to return a call, please leave the auditorium to do so. And remind everyone that the lecture is being recorded and broadcasted today. Thank you to those who are joining us from IU Health West, IU Health North, IU Health Arnett, and IU Health Ball Memorial. Our speaker today is Diane Meyer, and I'm actually going to give a much shorter introduction than I usually would do for such an esteemed visitor, because I know we all want to hear her and not me. Diane is the director of the Center to Advance Palliative Care, a national organization devoted to increasing the number and quality of palliative care programs in the United States. Under her leadership, the number of palliative care programs in U.S. hospitals has more than tripled in the last 10 years. She's also vice chair for public policy and professor of geriatrics and palliative medicine and the Gaisman professor of medical ethics at the Mount Sinai School of Medicine in New York City. In 2012, she was awarded the American Cancer Society Medal of Honor for cancer control in recognition of her pioneering leadership of the effort to bring non-hospice palliative care into mainstream medicine. In 2009-2010, she was a Health and Aging Policy Fellow in Washington, D.C., and in 2010, she was recognized by HealthLeaders as one of 20 Americans who make healthcare better. Finally, she's the recipient of a MacArthur Foundation Genius Award Fellowship in 2008. She's truly one of the most important people in healthcare today, and certainly one of the leaders in palliative care, and so we're very eager to hear from her and are glad that she's been able to join us here.
Can everybody hear me? It's working? Before we start, first of all, hi, and thank you very much for inviting me. It's really an honor to be here with so many international leaders in the fields of geriatrics and palliative medicine. But before we start, I'd really like to know who's here. So let me ask, how many people here are researchers? And how many clinicians primarily? How many docs? Nurses? Social work? Chaplaincy? Management, administration? Who am I forgetting? Music therapy. What else? Students? Psychology. Great. And also, before I start, I'd kind of like to hear from you guys what interests you about palliative care. What are the top-of-mind questions that you have about it that made you curious and made you come today, aside from somebody telling you you had to? Just because I want to be sure to address what your top-of-mind concerns are. Did anybody come in with some questions in their mind about palliative care? Palliative care and heart failure. Workforce issues. Yep. Why it takes so long for the patient, why it takes so long to get palliative care in place for the patient. The $64 question. Palliative care and ACOs. Okay, I'm going to stop there because I'm not sure I have enough time for all that, but does this work for advancing slide? So I have no disclosures. My objectives for today are initially to present palliative care in its historical
You are the first
context.
participant to join the conference.
Secondly, to talk about where we are now in 2013 in terms of the growth and development of the field. And then third, to talk about where I think we are going and in contrast to that, where we should be going. So I think many of you know that between the Middle Ages and early in the last century, in 1950s, life expectancy was between 20 to 50 years. The first hospices were actually established by the Crusaders in the Middle East, the Christian hordes going to convert everybody in the Middle East. And hospices were established as places for them to stop and sleep and gain energy on their trip. Churches, faith-based communities, were actually the first to create a place where poor, sick, and dying people could go to receive care. These were only for the poor because wealthy people stayed home. It was desirable to stay home. So people who had nowhere else to go received their care through church communities. And the vast majority of deaths, really up through the early 20th century, occurred at home, as opposed to the current situation. And in fact, there was a whole sort of cultural attention to the quality of that process. It was called ars moriendi, the art of dying. Attention was spent on leaving a legacy in words or objects for your survivors. There was a lot of attention to the impact of the loss of a member of the community on the health and well-being of the community, and that was manifested by a lot of rituals like wearing black, putting black ribbons on the door, delays in when you could, for example, remarry or re-enter the life of the community. And what these rituals were meant to do, and probably did do, was help the community come together to support one another when one of their group had been lost, and then help those who were bereaved to heal and then re-enter the community. Almost all of these rituals are no longer with us in modern America. And so this was the primary role of the family doc until about the middle of the last century, and it was to be present, because there wasn't much else that we could do. We had morphine. We didn't have antibiotics. We certainly didn't have ICUs. We didn't have chemotherapy. We had some surgery for major issues, but the role of the physician was to attend, be with the seriously ill person. And then we flipped from the Stone Age, and you'll see between the Stone Age and maybe 1900, only a slight gain in life expectancy. And the big leap occurred, why? What was the cause of the huge leap in life expectancy for the human species? No, clean water, public health, very simple measures. Telling the Broad Street pump handle, closing the Broad Street pump because it was pumping fecally infected water from the Thames into the London drinking supply. I mean, it was really basic things, separating drinking water from sewage. And the germ theory of disease, hand washing, that led to a marked decline in infant and maternal mortality. And that was the major reason for the huge leap in life expectancy around the time of the 19th century. And most of it, in fact, was not due to modern medicine. We got another leap with antibiotics and antisepsis of about another 7 to 8 years. Antibiotics came into common usage after World War II, so around 1950, 1960. But after that, the gain in life expectancy attributable to what we do here in this medical center, what we do at Mount Sinai, our ICUs, our angioplasty, our fifth-line chemotherapy, our complex surgeries, our cell therapy is on the order of maybe 1 year. And much of the reduction in, for example, cardiovascular mortality is not due to treatment, but due to prevention, reducing smoking, controlling hypertension. So just to humble us a little bit, because all the activity and all the money is in a part of the healthcare system that has relatively little impact on lifespan, survival of the species, which I think everybody here recognizes as the key metric, right? Survival. So life expectancy in the U.S. as of 2012, the median age of death in our country is 78 years. That places us, I don't know, something like 30th in developed nations worldwide. So we're not keeping up with other developed nations. The mean is a bit lower, the median is a bit lower for men than for women. Among those of us who make it to 65, though, the median age of death is 84, another 20 years. And this is because we didn't die in infancy or childbirth or of treatable bacterial infections earlier in our life. And among those of us who make it to 85, the median age of death is 92. Median. So if I were a public health person, this is where I would be looking in terms of what are the major public health threats to our country. And a gain of 30 years in life expectancy since 1900. Now think of evolution as a multi-million year phenomenon. This is a huge evolutionary leap in a very, very, fraction of a blink of an eye in evolutionary time. So here's the New Yorker with the doctor saying to the patient, the knees are the first thing to go. It's so interesting how the New Yorker is always way ahead in terms of the zeitgeist and sort of capturing the reality of life at the present. So what has the 20th century response to this longevity been? And this is only in the last 50 or 40 years. First of all, it is now, we expect to live a long life. That's not exceptional. It's not exceptional to have parents or grandparents in their 90s. We talk about it with admiration, but it's commonplace. We consider somebody who died in their 70s to have died too young. Never happened in human history before now. The other 20th century response to this longevity is essentially a medical industrial complex that has developed around the medical care of chronic conditions. So we've seen an exponential growth in hospitals, procedures, medicine, technology, in association with a mechanism for paying for it. That wasn't there really before World War II, insurance. Employment-linked insurance, and then in the 1960s, Medicare, guaranteeing access to care for all persons over 65. And the market followed assiduously these increasing sources of payment and grew up in response to the increasing sources of payment. So what ended up happening because of all this investment in the medical industrial complex had been that the experience, the ars moriendi, the experience of decline, dying, and death didn't have a place at the table anymore. Was kind of lost to the psyche of the healthcare system. And most of the modern hospice industry grew up in reaction against, or in reaction to, the neglect, almost the abandonment of seriously ill and dying persons. And the first person who developed the modern hospice was Cicely Saunders, who was a fascinating person because she started out as a nurse who was working with a pain doctor, working with a lot of traumatized World War II vets, and then saw that so much of their problem was social. So she went and got a social work degree. She was like a chronic student. And then she realized that even though she was a nurse and a social worker, she had no power. And the doctor she was working with told her to go to medical school if she wanted to have influence. So she did. So she was a one-woman interdisciplinary team. And through her own determination and vision, established St. Christopher's Hospice, which everybody here knows, I think, is a building. It is a place where you go to get care while you're dying. Very different from the model of hospice that we have in this country, although it's still the way many people think about it. She interacted with Florence Wald, who was the dean of the School of Nursing at Yale, who, I don't remember how they met, but Florence visited Sicily in England and came back and started the Connecticut Hospice. which was the first hospice in the United States, which was also a place. It's still a place. They also have home care. Right around that same time, another middle-aged woman, Elizabeth Kubler-Ross, a psychiatrist at the University of Chicago, did something totally revolutionary. She actually sat down and listened to dying patients. This was considered almost unseemly at the time. It was so countercultural and so kind of non-scientific and non-technical and just didn't fit the culture of medicine, and published a book about it. And if you haven't read On Death and Dying, I reread it recently. I think I had last read it in college or something, and it really influenced me and impressed me because the whole book is nothing but quotes and, basically script of what people said to her, and it's really quite remarkable and very powerful. And that book is among the, it's still in print. It's been translated into 27 languages and still very influential in terms of taking death and dying out of the closet and making it possible to talk about it. So hospice for a long time basically came from faith-based volunteer groups. There was no Medicare benefit paying for it until about 25 years ago. And the focus was almost entirely, and for all of these people, the founders, the focus was almost entirely on cancer for hospice. It just didn't occur to people conceptually that other people might need this type of care as well. And here's a picture of Sicily at St. Christopher's Hospice, and one of her famous quotes. It appears that many patients feel deserted by their doctors. Ideally, the doctor should remain the center of a team who work together to relieve where they cannot heal, to keep the patient's own struggle within his compass, and to bring hope and consolation. And there's Elizabeth Kubler-Ross at the University of Chicago in 1969. You can see the Gothic architecture and the ivy in the background. And here's Florence Wald, who established the first hospice in Connecticut in 1972. And through their work and through some very sophisticated lobbying, and this is also an interesting object lesson in how to get policy change, how these basically volunteers in a very sophisticated manner influence members of Congress to pass this new Medicare benefit, which was established in 1982, actually quite recently. It had enormous strengths because what it did was provide hospice care to people in their homes and provided a way of paying for it. So it markedly improved access. There's an intensive focus on families and their needs, and it led to significant and measurable improvement in care of the dying, primarily in the first part of the hospice benefit, those with cancer. But it has major weaknesses as well, and it's the weaknesses that are at the root of the growth of the palliative care movement in the United States. By law and by design, the eligibility criteria for hospice are limited to people with a prognosis of under 6 months if the disease follows its usual course. And, just to add insult to injury, the patient, him or herself, actually is required to sign a piece of paper saying that they agree that they are dying and they agree to give up regular Medicare. I mean, I don't know if statists wrote that part of the bill, but it is really cruel to ask people to sign that. And often, in my experience, trying to talk people into all the great things that hospice will give them, that's the place where they stop. They don't want to sign away their right to anything. And only when I say you can come in and come out at will, which most people don't know, will people agree. So why did they put these eligibility criteria in place? What were they hoping to do? They were hoping to frame the numerator. Like, of all people with serious illness, how are we going to control the numbers of people that turn to this benefit? They were trying to restrict the target population. The problem is there's an illusion in those criteria, and what's the illusion? We have no idea who's going to die in 6 months. And it's not because we're stupid. It's because we actually don't know, because there's enormous variation by individuals and by disease around when people are going to die. So what's the consequence of this? What has been the consequence of these eligibility criteria and access to hospice in the United States? Does anybody know what the median length of stay in hospice is? Remember, it's a 6-month benefit. It's 17 days. That's the median, and getting shorter as it's being tracked. 30% of hospice patients get it for less than 1 week, 10% for less than 24 hours, which makes good sense when you think about the fact that we're asking people to sign away their right to regular medical care. So I would wait if I could, especially if I could get good palliative care along with disease-modifying treatment. So while their intentions in terms of cost control and quality were good, the outcomes of the good intentions have been a very poor match of a Medicare benefit to the needs of seriously ill and dying people. So there was a great front page article in the New York Times in 2007 in which basically it talked about how hospices are punished if patients fail to die on time. That hospices are actually incented, because they get punished if people live too long, they're incented to have them die sooner. Now, what kind of a perverse federal policy is that? And here's the New York Times on this. Hospice providers across the country are facing the catastrophic financial consequence of what would otherwise seem a positive development. Their patients are living longer than expected. The refusal of patients to die according to actuarial schedules has led the federal government to demand that hospices repay hundreds of millions of dollars. So I don't know about you, but in our community, hospices will not take anyone with an uncertain prognosis because they're afraid they're going to be accused of fraud and abuse and made to pay fines. And that's a big part of the reason why length of stay is so short in hospices. It's driven by policy. So what about people who are not dying in a predictable or soon manner? The next very important piece of data was the support study, which was a $27 million study funded by the Robert Wood Johnson Foundation that tried to test in a randomized controlled trial a very rational intervention where patients and doctors were told about prognosis and offered options for care. And unfortunately, this intervention had absolutely no impact on outcomes. And in fact, what they found in this study was that the primary driver of location of death was number of hospital beds per capita in the community. It was completely supply side driven. If you had a lot of hospital beds in the community, people were much more likely to die in the hospital. If you had fewer hospital beds in the community, they were much more likely to die at home. It had nothing to do with preference. It had nothing to do with goals of care conversations or what physicians wanted. It was system variables. So what this study found hit the front page of every major newspaper in the United States. And what they found was that less than half of doctors even knew what their patients wanted. About 40% spent at least 10 days in an ICU. Half had what they described as moderate to severe pain at least half the time in their last 3 days of life. And 40 to 60% reported moderate to severe pain after a week in the hospital, and more than half these families experienced major financial burden, although they were 100% employed and had insurance or Medicare. The median age, I think, was 63 in this study. So it's about half Medicare and half not. And the interpretation by the press of these data were A, doctors don't care about patient suffering. B, doctors are profligate with the public purse, wasting money on people who are clearly dying. Those were the major take-homes. The interpretation by journalists, very different than those of us who work in these systems might have interpreted the data. But the result was, as in this cartoon, if it were my car, I'd disconnect it from the battery recharger, take it home, and let it die in its own garage. It created this notion that hospitals were not such a great place to be when you were seriously ill, and that you could not expect basic pain management, basic symptom assessment, basic conversations about what's important to you to happen. And to Robert Wood Johnson's enormous credit, even though this $27 million research project totally failed, you might have said they should have done some pilot work before they funded a $27 million RCT, but they didn't. They then proceeded to invest over $200 million in integrating palliative care into the U.S. healthcare system. As my project officer, Rosemary Gibson, said, into integrating palliative care into the genome of American medicine. So it wasn't only Robert Wood Johnson who made a huge investment. In fact, among all the major private sector philanthropists, George Soros, and lots of other regional and local foundations, the investment has been over $300 million since about 1990. That's a lot of money, and that's why I wish I could say it's because what we do is so important and so wonderful. It's because a lot of money was put in to scaling and diffusing this innovation by not the government, but by private sector philanthropy. So if you want to look for a poster child for effective private sector philanthropy, it's smoking cessation and palliative care in the United States, both of which owe their progress to very high levels of investment from the private sector. Rosemary Gibson was my project officer at Robert Wood Johnson, and I was quoting her when I talked about the genome of American medicine. These are just a few of the things that Robert Wood Johnson invested in. They invested in a generalist training curriculum so that an internist or an oncologist or a family practitioner could get a core curriculum on palliative care principles and practices. They invested in a nursing version of that, LNEC, which has trained hundreds of thousands of nurses in the United States and elsewhere in core content. They created a kind of clearinghouse of curricular content that anyone could use, ePERC. So it's free. You go online, you pull down slides, you pull down lesson plans, you pull down cases, you pull down exams to try to reduce the opportunity costs for teaching. They funded something that did a kind of let 1,000 flowers bloom. They tested palliative care in prisons. They tested palliative care in Alaska. They tested it in a NICU. They tested it in children just to see outside of hospice what would happen. They noticed that all the major textbooks in nursing and medicine, you could read those textbooks and be forgiven for believing that no one ever dies of these diseases because there was no discussion about the fact that people do die of these diseases and what is the physician or nurses or social workers' obligation to take care of people in that setting. So they basically named and shamed the textbook editors, and if you look at your textbooks now, they all cover palliative care through a naming and shaming process funded by Robert Wood Johnson. They invested heavily in public awareness. It was called Last Acts Partnership. Unfortunately, the public awareness they were driving was around death and dying, which no matter how much money you spend on it is never going to be something that appeals to the American public. So I don't think it was very effective for that reason. They invested in quality guidelines, and they invested a total of $60 million so far in the Center to Advance Palliative Care, which is the organization that I lead, which was designed to provide tools and technical assistance to frontline clinical teams looking to implement palliative care models across the country and across settings, and our job was to make it as easy as possible, to reduce opportunity costs, to give away best practices, to give away tools, calculators, brochures, marketing stuff, business case analyses, to help people get started. George Soros, who is, I think everybody knows, a very wealthy financier who made his money trading currencies, basically, did something different. So you saw on Robert Wood Johnson primarily invested in content, like curricular content or technical assistance. Soros invested in people, and this is a very important partner to the content investment. They invested in leaders, physicians, social work, and nursing leaders, who had a track record of productivity and effective leadership before, and then were bought out for their time, like 50% of our time for 3 years, to try to take that leadership skill and apply it to developing palliative care programs. And this was unbelievably effective. It was a much smaller investment, but had by far the largest impact in my view. really taught me how critical leadership is. Leadership support, leadership development. Doesn't matter what content is out there. If you can't execute, if you can't implement, the content will just languish. And I thought, and it was interesting because I asked Rosemary and I asked Kathy Foley and Susan Block, who ran the Project on Death in America Faculty Scholars Program, if this was a conscious strategy to have one funder do content development and the other funder do leadership development, and it was not a conscious strategy. But it worked. And today, in fact, the major leaders in the field were Project on Death in America faculty scholars. And we work together very closely. So that's Kathy Foley on the left and Susan Block on the right. And I am grateful to them for giving me my right career path, helping me find my place. And this is one of my fellow Project on Death in America faculty scholars. We were in the same cohort. This is Charles von Gunten, who was an oncologist at Northwestern and established the palliative care team at Northwestern. And this characterizes these first cohorts of leaders. And he said, here are some important messages for getting started. Each individual program begins in a unique place with a unique history and set of people. And you start with what you've got. The second important message is persistence. You have to have this strong vision and work at it persistently over time, like don't give up, don't take no for an answer. Over time, through some serendipity and a lot of perseverance, by a small group of involved, committed people, we built an effective program. Also remember, it is better to beg forgiveness than to ask permission. It's not like there was some giant committee in the hospital that said, should we have this palliative care unit? When you begin, you just start doing it. So these were the sort of the character of the people that started to build the field of palliative care, and it was a sort of rebellious group, I would say. So the present, we've now got over 1,900 hospital palliative care teams in the U.S. that are of highly variable quality, penetration, that is, how many patients in need do they actually see, staffing, and ability to outreach beyond the walls of the hospital. We have a brand new nursing and medical subspecialty with board certifying exams. We have highly variable and I would say consistently inadequate undergraduate and graduate medical, nursing, and social work education in the core principles and practices of palliative care. And we have a rapidly changing cognitive frame for palliative care in the context of an aging population with multiple chronic conditions, frailty, and functional impairment, shifting from the brink of death cancer population to the long-term chronically ill elderly. This is the growth in hospital palliative care in the last 10 years. And this is the conceptual frame shift where you see that from the point of diagnosis with Alzheimer's, with cancer, with stage 4 congestive heart failure, the model is that patients should receive palliative approaches to care at the same time as curative or disease-modifying or life-prolonging treatment. That it's not one or the other, as is the case with hospice, but it's both and. And the conceptualization is the added layer of support. And the sine wave, I had to get a colleague to draw that sine wave. I couldn't figure out how to do that on PowerPoint. But the sine wave is accurate. Those of us who take care of chronically ill people know people are stable, then they have some acute decompensation, they get rescue medicine. We send them back out a little worse than when they started, and it just keeps happening like that. And you need more rescue medicine during the acute crisis and more support, palliative, family support, practical support, symptom management during the stable period. But it's not either or. And the point at which hospice becomes relevant is way over here on the right when disease-directed therapies are no longer effective, no longer helping the patient, or their burden outweighs their benefit. And for many patients, that is very late in the course of illness, particularly those with cancer, heart failure, COPD. We have effective life-prolonging treatments for these diseases. And we shouldn't be saying, well, you can have hospice, but only if you give up life-prolonging treatment, and that's what we do. So we do have, in addition, a growing body of evidence on the quality and cost benefits of palliative care across care settings and patient populations. And the way policymakers talk about this is they talk about the value equation. Anybody here know what the value equation is? So value in healthcare is quality in the numerator and cost in the denominator. So can anybody think of a very high quality medical intervention? I mean high value medical intervention that really saves lives and does so at very low cost? Immunization is the classic example of a really high value medical intervention. Public health initiatives. They keep the water, keep the food safe. Right? The pennies per person save millions of lives. What might be a low value healthcare intervention? Something that costs a huge amount and has minimal intervention. Sorry? ECMO. Yeah? Well, ICU care for people with end-stage dementia and pneumonia would be, one extreme example. Fifth and sixth line chemotherapy that costs a huge amount in many of these drugs, $90,000 a year, $10,000 per dose, with minimal or no life expectancy benefit. Those are low-value interventions. So the holy grail in the healthcare world of today is to find interventions that do both, that improve quality and reduce cost. And if you listen to Don Berwick, the great white horse is to reduce cost as an epiphenomenon of improving quality. So cost goes down because people don't come to the ED in a pain crisis, because the family caregiver isn't exhausted and burned out because he or she is getting help and support at home. That we improve quality, and because people are well cared for where they live and feel safe and attended to, they don't turn to the acute care system as they do now because it's the only game in town. And these are some of the outcomes that have been shown in studies to improve associated with palliative care. On the left, the quality measures, and on the right, the utilization measures. These are data from Jen Temmel. This was a randomized controlled trial of early palliative care in a cancer center setting. These were people with newly diagnosed stage 3 and 4 non-small cell lung cancer who were randomly assigned to usual cancer care at Mass General. That was the control group. Or to the intervention group, which got an added layer of palliative care support in addition to best cancer. Now, Mass General is arguably the best place in the world to go if you have lung cancer. It is a superb lung cancer program, very strongly reputed. So this randomized controlled trial, the primary outcomes were things like quality of life, pain, depression, family satisfaction. And a secondary outcome was survival because no one expected to see a difference. So this is a Kaplan-Meier statistic, and the blue curve is the usual cancer care, and the red curve is the palliative care. And the palliative care patients lived almost 3 months longer than the usual care patients. And before we go on, let me ask you guys, let's say this study is replicated, hasn't been yet. Let's say we find similar findings in other patient populations, non-cancer, not Harvard. Harvard's not replicable. But for the sake of argument, let's assume that this is true. Can be replicated. What might be the mechanisms where palliative care would help you live longer? And why would better symptom management help you live longer? Symptoms are bad for you. Whether it's because they contribute to the inflammatory syndrome, that is the precursor of death, or whether because you're in pain you sort of involute and stay in bed and turn away from the world. It's not clear. But in a number of different populations, uncontrolled pain is a very strong predictor of mortality. Yeah. Why would that help your life, help you live longer, though? Yeah. So it's sort of understanding who your patient and the family is and what matters to them. Right. Right. So when I talk about this to oncologists, they say, yeah, that sounds good, but you haven't told me the mechanism by which it might lead to a longer life. Anybody? Yeah, less iatrogenesis. So this group was much less likely to receive chemotherapy in the last month of life, which we know doesn't help and probably hurts. They were much less likely to be hospitalized. What happens to you if you're an immunosuppressed cancer patient, getting chemo and radiation, and you come to my hospital and you get C. diff? You die. I mean, hospitals are really dangerous for immunologically vulnerable patients, like frail elderly, like people with cancer that's being treated. And then there's some data on immunomodulatory effects of having pain relief, depression treated. Depression is a major predictor of mortality in every diagnostic group in which it's been looked at. If you're demented and have depression, you die sooner. If you have stroke and depression, you die sooner. Heart failure, COPD, cancer, depression, probably mediated by inflammatory processes, is a strong predictor of mortality. And depression was reduced by 75% in the palliative care group. Other people have suggested that maybe families feeling safe and supported, they were less likely to freak out and call 911. They knew who they could reach for help. We don't know what the mechanisms are, and it's really important to address it because similar findings in a number of hospice studies have been done. That people in hospice compared to a propensity and instrumental variable match control live longer. It's the opposite of the received person. I think it's probably largely reduced iatrogenesis, but who knows? This is a... Oh, yeah. Yeah, oh, sorry. I cut some slides. I had too many slides. So pain and other symptoms were better. Quality of life was better. Major depression was reduced by 75%. Family bereavement outcomes were better. To me, it's a given. The quality improved. What wasn't a given was the length of life. Yes, you have a very good point. And they did, and those were their primary outcomes, because that's what they were looking to influence. This is another RCT in Kaiser. And Kaiser, as you guys know, is a staff model HMO that works under a single budget. Right? So they don't have fee-for-service incentives to do more and more and more to people. They have incentives to spend money in the best possible way for their population. And this was a group of elderly Medicare beneficiaries in Kaiser with COPD, CHF, and cancer, who were randomly assigned to usual certified home health agency home care, like we do with its limitations on duration and intensity of service, or a palliative home care model, which was primarily NP and social worker driven, but also had doctors who were available. And if you just look at the left, the light blue bar is the palliative home care, the dark blue bar is the regular Medicare home care. And you were only looking at this and you were running the home care system, you'd say, well, that's great, 3 times more visits in the palliative care group. Who's going to pay for that? Way too expensive. Forget it. We can't do this. I don't care about the quality of it. But it's Kaiser. So they were able to look at what happened in all the other settings of care as a result of this home care. And you can see for yourself huge and dramatic reductions in acute care utilization, in the number of doctor visits, in ED visits, and in skilled nursing facility visits, because the patient's needs were being met at home. I mean, this is really not complicated. It's so obvious, but we can't do this in Medicare as it is now. I think this model is the future of the healthcare system. I think we're going to see a lot more money and effort being shifted out of acute care and out of facility-based care and into the home. And I think it will improve quality and it will save money. These are data from Sean Morrison and our team looking at cost avoidance associated with hospital palliative care. This was an all-payer group, about 50%, Medicare about 30%, Medicaid about 20% commercial payer, 8 hospitals. This was all Medicaid in 4 largely Medicaid-funded hospitals in New York State. We found an even larger savings in the Medicaid-only group than in the mixed all-payer group. And in fact, this study published in Health Affairs in 2011 led 3 months later to legislation because they were doing the Medicaid redesign task force in New York. So now all providers who receive Medicaid funding are required to assess and provide access to health in New York. So what's the national context? The U.S. has very poor quality of care compared to peer nations. We rank 40th in quality indices like infant and maternal mortality and acute illness that's preventable by medical care. We have more than 100,000 deaths per year from preventable medical errors, largely like hospital-acquired infections. 48 million uninsured, and we have health care that is the #1 cause of personal bankruptcy in the United States. There is no other developed nation where that is true. And we are driving our country into an economic ditch with healthcare spending. And by the way, lest you think it's mostly Medicare beneficiaries driving this, it's mostly private sector spending that's driving this. About half of the spending, the excess spending, is on the private side. Proportionally, we're spending exactly the same amount of public dollars as other countries. So only in the United States do you see headlines like this. This was a 2-professional family, both parents insured, owned their own home, had a baby with a congenital mitochondrial disorder, who bankrupted, got to the ceiling on both insurance plans, and lost their home. Baby died, age 4, and family was destroyed in that process. This is, a white upper middle class family that this happened to. I still don't understand why there isn't a political uprising about this in this country. This is Massachusetts data. You guys know the federal government can deficit spend, but states cannot deficit spend. States must balance their budget. So if you are increasing your healthcare spending, as the state of Massachusetts did over the last 10 years by 80%, everything else has to be cut. Fire, police, parks, roads, air quality, parks, education, early childhood, everything else that makes life worth living, that makes a society responsive to the needs of people, is going away so that we can pay for destination ventricular assisted devices under Medicaid, which, by the way, we are paying for under Medicaid. So we are sucking the marrow out of our societies with healthcare spending and not realizing that it's a trade-off. It's a zero-sum game. So I would argue that palliative care type models and principles are central to the nation's future. We know that healthcare spending is highly concentrated, that 5% of the sickest, most complicated patients account for half, and it varies by population, of all healthcare spending. But our patient population, frail elders with functional impairment, seriously ill people, it's not everybody that's driving this spending. It's a very small subset of the population that's driving this spending. So our expertise in improving quality is critical to rescuing our healthcare system. So here's a real case. This was an 84-year-old woman, Mrs. S., who we met in the ED. She was admitted for management of pain from metastatic non-small cell lung cancer. Her pain was 8 out of 10 on admission. She was taking a gram of Tylenol every 4 hours around the clock, 6 grams a day for that. She'd been admitted 4 times in the prior 6 months, twice for pain, once for weakness and falls, and once for altered mental status that turned out to be due to a fecal infection. 4 admissions, all about symptoms. Her primary caregiver is her 87-year-old husband. And their only access to the healthcare system is their oncologist, basically, at this point. So this is a quote from Mrs. S. I told the doctor I never wanted to go back to the hospital again. Here's her goals. It's torture. You have no control and can't do anything for yourself. And you get weaker and sicker every time I'm there. It feels like I'll never get out. And Mr. S., horribly guilt-ridden and distraught that he had abrogated her wishes, said, she hates being in the hospital, but what could I do? The pain was terrible. I couldn't reach the oncologist. I couldn't even move her myself, so I called the ambulance. It was the only thing I could do, in fact, because there was no safety. So, in fact, he had called the oncologist really not that late, 7 p.m., and the tape said, if this is a medical emergency, call 911. So he did. She wasn't speaking to him at that point. She was furious that he had called him. Amor, yeah. It's sort of a busman's holiday movie. Exactly. And will we ever get to the point of designing a healthcare system that would have allowed her wishes to be honored and him to get the support he needed? So clearly you see on the left there what this family was facing, but what's the consequence for health systems? All of a sudden there are negative consequences because hospitals and health systems are now going to be punished for 30-day readmissions, for death in hospital, for low satisfaction with care. So all of a sudden there's an incentive to do something about this that did not exist before the Affordable Care Act. And what that does is give us leverage. This is the business case for the delivery of high-quality care to the sickest 5% in the community, because these are the people that are going to bankrupt our ACOs and our healthcare system. So the future will be this: not enough to have access in hospitals. Most illness occurs at home and in communities. We need palliative care at home without regard to prognosis, and assure access across settings and stages of illness. I am running out of time. So just briefly, this is how my organization thinks about social change. And it's this virtuous circle between frontline technical assistance to reduce opportunity costs and influencing policy. And the reason we can influence policy is because there are now 2,000 hospital palliative care teams in the U.S. So every congressional district and every senator has palliative care leaders in his district who come and talk to him. So we have attention. And that's how the policy game works in the United States. And these are our goals: that patients and families will know what it is and demand it, that doctors, nurses, and social workers will have the skills to deliver it, and that all healthcare institutions will support and deliver it this commitment. We do this through very assiduous attention to partnerships with other national organizations, including disease-specific organizations like the American Heart Association, the American Cancer Society, as well as other organized medicine organizations. So just to give you an example of the kind of public awareness campaign we're trying to do, we did this with the American Cancer Society. You see it's a ballet dancer's feet, and in black Arial font it says cancer, and then there's a purple vertical that says dancer. And it makes the point that palliative care is about the person, not just the disease. Their second ad in this series is a 3-year-old with curly hair on swings, and it says stage 3 in black Arial font, and then a crayon crosses out the ST. This is why you need professional help to do public awareness campaigns. I would never think of this, but this, advertising people are brilliantly creative. So this is what we need. Seem to be stuck. Anybody help me? Can't move forward. All right, I'll just talk. So I think the second priority, in addition to public awareness, is the issue of education. There will never be enough palliative care docs, nurses, social workers in my lifetime or 6 lifetimes to manage the care of these sickest 5 to 10% of patients. So our job has to not be to replicate more of ourselves, because that's not even beginning to address the need. Our job is generalist training. Our job is making sure that every frontline nurse in a nursing home, every floor nurse, every oncologist, every critical care doc has these skills and can deliver this kind of care with the specialists available for the really complicated that the primary team can't manage. And then the third goal is to make sure that you can't get paid as a hospital or a nursing home or a home care agency unless you're delivering. Oh, I have to show you this. This is such a great picture. This is the New Yorker Caption contest, my favorite page in the New Yorker. So it's a doctor. I'm sorry about the quality of the copy. The doctor, he should be facing a computer, but he's facing his chart. And behind him is a patient in a coffin. And he's saying, any stiffness? Sorry about the wave. Any family history with death? And the New Yorker thinks this is funny, but those of us who work in geriatrics or palliative care in hospitals know this is true. That many of our colleagues actually do not recognize the dying syndrome. And that's why people end up in the ICU, because it's a syndrome. And you have to be trained to recognize it and know what your professional obligations are. And many of our colleagues never got that training. So the big focus for us is generalist level training. We're going to be developing massive online open courses to do some of the core content training, and then trying to scale communications education, because communication is the biggest gap. And in terms of getting hospitals and nursing homes to do this, there are several policy levers. One is joint commission accreditation. Does everybody know why hospitals have to be joint commission accredited? Why do they care? If you're not Joint Commission accredited, you don't get paid. So there is nothing more motivating to hospitals, nursing homes, home care agencies than their accreditation, because they don't survive without it. So if you can get the accrediting bodies to require as standard of care these types of models, you will see it universally very quickly. So that's the direction we're focusing on now. We're also focusing on trying to get palliative care measures into value-based purchasing, and trying to get access to palliative care across all settings where patients receive care. But one point I want to make to you guys is that we haven't talked about who has the strongest incentive to keep people safely at home, and it's the payer. So if you are not meeting with your regional payers, your dominant payers, Medicare Advantage, Medicaid long-term care, in New York it's United Healthcare and Aetna, to get them to pay for these models. They want to. They just can't find the providers willing to do it. They have an incredibly strong incentive. So we need to sort of get out of how we think about this and realize that our best partners here are private sector payers. And I am going to stop with that. Lots of people are doing really good stuff around the country. The future is here now. We just need to make sure it is evenly distributed. Thank you. Yeah, I'll stay here if folks have questions. How's that?